I think we can get started. Yeah? Okay, good. Thank you for coming to our talk. This is best practice updates on management of agitation. Let me just our disclosures. And the objectives and agenda today, we'll be going through a case that is actually kind of a real case based from our case review at one of our institutions. And using the case, we'll be reviewing updated research and evidence-based best practices for managing acute agitation, at the same time ensuring that our staff stay safe. We'll be covering these 4 domains. First is verbal de-escalation of our patients, and then followed by mitigation of bias in agitation management, and we'll talk about medication management for agitation, and lastly, wrapping up with workplace violence prevention mitigation. So why are we talking about this? As clinicians, we have a duty to safely care for our patients when they're agitated, at the same time protecting their patient rights. But at the same time, we're balancing that with the increase in workplace violence that we're seeing nationally, and also our duty to keep our colleagues safe. And this interconnectedness is what brought this group together. It's a large panel, but experts in this field of agitation management and workplace violence. So with that, we'll start with our first case. So we have a 21-year-old African-American male patient who has a history of schizophrenia, who's presenting to the emergency department after his family reported that he was staying in unlocked cars and sleeping in the car. They're worried that he might be using drugs and alcohol with his new friends. On arrival, so he has a past medical history of schizophrenia and 1 prior hospitalization related to that. And he is prescribed olanzapine, which we're not sure if he's taking. On arrival, he comes with tachycardia and hypertension. He looks disheveled. He's ambulating, but pacing around. He's intermittently screaming, "I am God." He's laughing and crying. And he has a very tangential speech. So with that, I'm going to invite our first set of discussants, Dr. Rapolo, Brablik, and also Dr. Shaw. Do you guys want to come up? Yeah, here we go. All right, so some of the questions that we had come up with regarding verbal de-escalation include, how do you actually assess the level of agitation in a patient who's coming in with acute agitation? And what are some basic verbal de-escalation strategies can you use to engage a patient, especially when a patient is presenting with acute psychosis and hallucination? And how do you know when the verbal de-escalation is not working and that you have to move towards restrictive strategies? And then lastly, how do you balance this with resource challenges related to capacity constraints?
Okay. I guess I don't think this is on. Oh, it is. Can you hear me? I'll just talk loudly. So, I think when they first come in, trying to do like a quick check on the levels of agitation is important. The first thing, obviously, is to remember both safety of the patient, but also safety of the staff. And so, in a lot of institutions, they've developed kind of behavioral response teams to try and respond to the agitation, but ultimately it's going to depend on what you're seeing. You do want to consider like the medical etiologies, and so I think we all know the impending sense of doom is actually something that can have a medical etiology, right? And so considering like the age, the vitals, running through your like very quick differential to make sure that we're not missing, right, like a huge PE or a SEMI for what we actually think is just like agitation. And then once that's happening, I think there's actually a lot of different agitation scoring and different scales that you can use, kind of like the way that we use GCS as like a shorthand, that when you use things like the BARS, behavioral activity rating scale, right, people will then kind of have a shared definition of what are the behaviors and the level of agitation that you're seeing.
So I'm going to talk to you about de-escalation. And de-escalation sounds like a big word, but it's really simple, and you guys are all brilliant in this room, and it's not rocket science and something we should be doing. I learned about this several years ago when I was seeing a lot of physical assaults in the emergency department, and I went to a pre-conference for SAEM and heard Dr. Wilson here, who was one of the authors for the Beta Guidelines, which is where I kind of took this from. It's a series of articles written in 2012 by just a collaboration with psychiatry and emergency medicine. And other people, pharmacists, a lot of other people. But so I read all of these articles, and I'm just going to go over these strategies, if you will, but I think the best way to talk about it is to talk about a case. And this is a real case, and probably my favorite case when it comes to agitation. This was a very severely agitated guy. I was at Parkland Hospital then, and the nurses came out to me like they would do, and they say, I need whatever drugs. This guy's really agitated. There's a bunch of people holding him down. And so all those words, which they could have just said, like, I've got this guy who's got a bars of 7, and we would have all known what that meant. So I go into the room, and my old me, by the way, before I read these articles, would have been ordering the drug, right? It was a busy emergency department. I had a lot of things to do. But I went over and I assessed the patient. And when I went into the room, there was this guy severely agitated and a bunch of people holding him down. Techs, nurses, police were there. And just remember, and you probably heard this before, is that most physical assaults happen during that containment process, right? And so I could have ordered the drugs. We could have physically restrained him and did this major workup, had CT labs, all that stuff that we normally do. But I talked to him. I asked the nurse, I go, what's his name? So I kept calling him. I'm like, Mr. Smith, I'm Dr. Apollo. I'm here to help you. And I could kind of see his face in between all the restraints and the commotion. And so finally he looked at me, and he had tears in his eyes, and I got him to engage. At that point, I kind of knew he could hear what I was saying, right? So, and we'll be talking about nonverbal. Marie is going to go into that. But you don't want to be provocative. I mean, this guy's already agitated, and I really didn't know why he was agitated. We didn't have any history on him, but you don't want to make things worse. You don't want to be provocative. And so when I saw that he was getting a little bit more relaxed, you can just tell the look in his face, the tension in his muscles, just the fighting was going down. And so I asked the people gradually that were around him to step out of the room, right? So safety is first. I kept an officer because I didn't know what this guy was capable of, and I was just slowly trying to de-escalate him, but I was trying not to make things worse. If you have a guy who's schizophrenic on meth and you're all attacking him, what is he going to do? He's going to fight back, and so you just don't want to do that. So respect their personal space. So you just kind of got to feel who you're dealing with. The other thing is it's also a safety issue. So you want to just make sure you keep like a 2 arms length from them, but also just kind of respecting him and not being confrontational. And she'll talk more about that, but establish eye contact and verbal contact. And so I kept saying the same thing with my simple and clear language, who I was and what my goal was, and that was to help him and convincing him that what I was saying was true. And then agree to disagree. Like, you don't want to agree with like some of his hallucinations, but I was agreeing. I'm like, I agree that you're frustrated. I agree that you don't want to be restrained. I agree that you want to get out of the emergency department. That we have in common, and that was kind of appropriate. Getting on his side, trying to get him to partner with me. Defining boundaries. Like, there are certain things that are just unacceptable. People yelling and screaming, throwing things, being combative, trying to hurt people, that is unacceptable. But if you can convey that, I respect you, you got to respect me, and we're going to work together in trying to get the same goal, which is getting him out of the ER, right? And so the other thing is just identify their wants. There might be something that they want, even like certain acts of kindness that we do, giving them food, giving them a blanket, or maybe there's just something that's causing their escalation and their agitation, but giving them choices. So, I mean, sometimes they do need medications, but the right way to do it is to get them to partner with you and giving them an oral agent in a very non-coercive way. But this guy didn't need medications. I started talking to him, I got his attention, and I could immediately tell that he had some kind of speech impediment. So I actually pulled up a chair, and in what seemed like a long time, but in ER hours, it was like 10 minutes, but still it was a good investment because I could have done a lot of other things. I could have medicated him, restrained him, and done all that stuff. But he started talking to me. And I learned that he was getting sexually assaulted at his group home, and they just kept bringing him back. So of course he's going to fight back, and nobody took the time to listen to him. So after that, I realized that, he doesn't need medication, he doesn't need physical restraint, he doesn't need a diagnostic workup, he needs a social worker, and he needs a new group home, and that's what we did, and he was out of the emergency department within, 3 hours, which is awesome. So it was a victory, and that's how de-escalation can be very powerful. You also want to deprive your patient. If you do end up having to do something, when you have the situation, talk to them, but then talk to your staff, because they may be wondering, why aren't you restraining him? And may be going against what they think is supposed to be done, so that could be really helpful. So next.
Great, thanks. Is mine on? Not so much. Okay, thank you, Dr. Rapolo, and I really liked what you said about everybody can do de-escalation. We're smart, we can do this, it's easy, and I agree, but also just like everybody in this room can put in a central line, that took practice, right? How many residents do I have in the room? So de-escalation is a skill, I would tell you all, just like the procedures we all train to do, and you will get better with practice. And that story Lynn told, she's been working at this for years, and that was a very skillful de-escalation by somebody who's been doing this a long time. Start practicing now, and I want to give you guys some tools when you think about how you're going to de-escalate a patient. And my friend Mark was just helping me a second ago until he moved his hands with his nonverbal communication. That was, I don't like that either. This work comes out of the psychology literature, and in the 70s, I forget the man's name, but famous psychologist broke communication down and showed us that really only 7% of what we communicate are via our words, and 93% is communicated by our body and our positioning. And one of my favorite positions to de-escalate from is sort of a leaning position that Mark's going to demonstrate now. With his hands crossed in front of him, we can see his hands. It's really non-threatening, and he's really, thinking about how can I be not big and not taking up space and not puffing up my chest, but how can I look approachable, visible, and sort of non-assuming. That's good. I love it. So Mark has also been doing this a long time. Thank you, Mark. And so that's something to think about. Think about your position in your body and what you're conveying with your body. Also, so this is really important. When we're de-escalating, that implies that something has escalated, right? So people are getting upset, people's emotions are high. Your patient may have said things to you that hurt your feelings. And it's important to remember that our patient isn't thinking about the impact on you. They're exploding, they're sort of emoting. And it's really important, I think, for us to acknowledge, well, gosh, this is having an impact on me, and it's hard, and I'm upset. I'm gonna set that to the side, and I'm gonna try to understand what this person's intent is. And I think not only think about your patient's impact versus intent, but think about yours. What impact are your statements having on the patient? Is what you're saying landing with the patient in the way you'd like? Or are they getting more heated and more escalated? And if so, why? And how can you approach this from a different direction? And then we're going to talk a little bit about patients who are acutely psychotic or altered. And Casey, what was the phrase we were going to use? Impaired reality testing? Impaired reality testing. So impaired reality testing means that they aren't understanding the reality they're in, and they're testing to try to understand what is very obvious to those of us who aren't experiencing psychosis. So if this is happening to your patient, you may not be able to de-escalate in ways you would with a different patient. And in that case, you want to think about who is the most qualified person in the room to be this patient's advocate, to interface for this patient. It might be the person with the most training, but it might be someone your patient is telling you, I identify with this person. I like this. I want this person to work with me. So look for those cues and be open to those cues. Actually, this slide reminds me I wanted to share a story from a recent clinical encounter. I had a patient who was really, I don't want that nurse. She hates me. I don't like her. So immediately I said, okay, that's fine. We'll trade care team members. And I said, hey, do you mind just swapping assignments? And they did. The nurse did, and the patient, had a better relationship, therapeutic relationship, or whatever you want to call it, with their nurse. And I didn't think about the impact on my care team member, on my nurse. She went to the break room. She was in tears. She said, oh, that doctor doesn't like me. She thinks I'm not good at my job. And so then I had to unpack that with her and meet with her. And part of agitation management, I think, is thinking about your team and also managing your team. So it's very complicated. Focus on your patient's basic needs. We all know about turkey sandwich bargaining. And that's not wrong. That is right. Because you can find that common ground and that uniting factor there. I mean, we get hungry on shift. I'm really grumpy when I'm hungry. And then you can talk about medication options if that's something that you can negotiate on with the patient, depending on the phase of escalation you're in. Okay.
So this is a great tool, but what if it doesn't work? Doesn't always work. How many of you have either been physically assaulted or saw somebody physically assaulted in the emergency department, right? A lot of people, okay? So what we're practicing or sharing with you today is effective and has reduced my physical assaults of anybody working with me and me in 8 years to 0. Okay, I haven't seen one. I haven't had one. So, however, okay, sometimes it just doesn't work. And you might have that patient that you gotta think about it. Are they at danger to themselves? Are they at danger to your staff? Are they at danger to their environment? Are they about to throw things? And you can try to de-escalate them, and it's very powerful. It has reduced my physical restraint and forced medication by, 80%. But if it fails, you just got to pull the trigger, but you need to safely do so, and we're going to be talking to you about that. And what happens is those are the questions, all these safety issues that I just mentioned after your de-escalation. And when you do this a lot, you just kind of get a sense. I can determine and pull that trigger within a minute. And you just need to try it, though, but always try it. Even if your patient's severely agitated, it's still worth it.
And then kind of our last slide was thinking about, now I'm scared about feedback, was thinking about, the de-escalation with resources challenge. And so I think a lot of times actually early identification, early intervention is more helpful, right? If you see the patient starting to get irritated, now's not the time to just avoid eye contact, walk a little faster by the bed, right? Trying to address are you starting to get frustrated? Are there things that I can answer for you about your care plan and things will help. Whereas if you're going, hour 6 into your shift, someone's screaming and then you have to be hi, I'm your doctor. I'm so sorry. What's going on? You kind of missed the boat. A lot of these patients can be de-escalated, and then they can also escalate. And then really the last thing was sometimes less is more. And so, I've had the situation where you have your behavioral response team and there's 20 people in there. And then you kind of listen and you're like, oh, I think if you actually just had an iPad and just watched YouTube, he'd actually be much more calm, right? And so decreasing your environmental stimuli and just kind of meeting the patient where they're at can go a long ways. Okay.
All right, so now moving on to the case. So this is from the most recent nurse's note from earlier today, which states that the patient was saying, "What's up?" and was flexing the arm at the female sitter and unable to redirect the patient, so therefore patient is placed in 4-point restraint and receive 5-50. And 30 minutes later, it says patient remains in restraint and patient is unwilling to cooperate, no evidence of learning or willingness to work with staff. With that, I'm going to invite Dr. Brookman, Wong, and Dr. Annette to come up and talk about the case. So I think what's concerning from that excerpt from the case is, this is an African-American male who's coming in psychotic, and we're concerned that the perception may have led to some of the decisions that were made, as well as the notes that were written in the chart. So with that, what are some risk factors for patients receiving differential care? And what are some strategies for tackling implicit bias? And how can we have this conversation with the staff who are caring for the patient? And what does your institute do to foster an environment where you can talk about these things?
So, we wanted to start with some of the risk factors for agitation. Ambrose, if we can just go back one slide back, The previous slide. Yep, there you go. So just the risk factors. So, evidence shows that there is, it's Black, race and ethnic minority, Black, Hispanic, uninsured, homeless, also mental illness, including substance use disorders, and of course, a previous history of violence. Now, is this the stats say this? But is it just pure coincidence, or there is some kind of mystery bias going on? So this is a good segue to talk about, there's a lot of literature, people suggesting about the role of implicit bias in terms of, decision making, when to use restraint or not, how long or to use the de-escalation strategies. So obviously, a big thing about the implicit bias is, your staff perceived perception of safety, like threat of risk from this individual in front of you. If your prior experience teaches you, a Black person or someone with mental illness or certain diagnosis like dementia, schizophrenia, which are medically prone to higher risk of, agitation, you would probably have that already in your mental framework going into your decision making. So that's a lot of it for implicit bias. There isn't, much to sort of measure, because all of this is subconscious. So how can we address something without measuring? So that's the tricky part. And I guess in terms of mitigating implicit bias, we need to start looking at some of the systemic factors. One of the systemic factors that comes to mind is we all know about the behavioral health safety flags. This is meant to be, to flag those patients in the EHR who've had past history of violence. What happens, it was intended to be a safety measure, but what ended up happening is, there are lots of outdated safety flags. Someone who's, punched someone 10 years ago, is this person still a risk? What level of violence qualifies to be an FYI or safety alert? So there's actually data showing that even the patients who get attached with safety alerts are labeled as risk. There is, ethnic minority, Black, Hispanic. So these are not, mere coincidence. That's where we were going to start. And in terms of strategies, of course, the first thing we start looking at the data. So individual, institutional, and state level data as to looking at the disparities in the use of restraints. In terms of organizational policy and climate, you're the hospital leadership to be able to open and acknowledge the role of bias and, having trainings to de-bias or raise awareness for implicit bias among healthcare staff. In terms of protocols or restraint checklists that you can use to, go through in your mind, and each organization can have their own, did I go through the best practice evidence guidelines and engage in de-escalation strategies long enough to be able to rationalize a restraint use. There's, pros and again, causes, pluses and minuses, and there are always people on both sides of the aisle of that. But at least, we wanted something to come out of this workshop. It would be to acknowledge this as a challenge and start the discussion towards finding more about it.
Sure. Can you forward on to the next thing? Thank you. Yeah, so thank you. I think that was actually kind of an overview of what we're going to go through in these slides. So just first of all, we know that we have documented and Dr. Wong has led many of these studies, but all really across the country. We know that certain patients are restrained more often than others. And some of the factors that you already mentioned, such as race, ethnicity, language, presence of a psychotic disorder, being unhoused, these all kind of come out as big risk factors. But even controlling for some of these things, race, still is a big risk factor for restraint. And so this is something that has made us really look at, why is this and what can we do about this in our care teams? Next slide. When thinking about why, what might bias us towards restraining one person more than another, we really have to think about the different, systemic and structural factors that may be playing into this, the institutional factors, what's going on in our own hospital, then what's going on the interpersonal level between staff members, and then what we're getting from the patient. Next slide. So thinking about an example of a systemic example here, this is an article that looked at to what degree police transport, the fact that someone comes in with police, might affect a team's decision to restrain them, and that this can be a structural mediator for this bias that we see, right? So someone comes in with police, you sort of assume they're dangerous. Well, you have police that are more involved in certain neighborhoods than others, and so you sort of have structural racism around policing in our country that then comes into play when it rolls into your emergency department. So that's sort of at the structural level. Next slide. And then we've talked already about behavioral flags. So now this is really going to the institutional level, right? We're trying to figure out ways to keep our institutions safe. And so, one technique that I think a lot of institutions use is if somebody has had bad behavior before or been a difficult patient, that we put a flag in their chart. Well, we've also seen, though, that in many systems that Black patients get flags more often than other patients, and there are real disparities in care that seems to follow. So patients may have longer wait times to see a clinician, longer wait times to be roomed, less labs and testing. So this is sort of an example of where this may be happening at the institution, again, before you even really get involved in the patient. Next slide. And then there comes into, you walk into the room, right? And I think we really think about the sort of structural stuff, and we're talking about narrowing in on racism, really interacts with bias, your interpersonal bias, and then also trauma. I mean, I think of structural racism as being a trauma that we all have collectively experienced and continue to experience. And then you also have the trauma that you bring to the room, as well as your patients. And these things are all interacting together. And so one way that a technique to talk about this with your staff that is, I think, less damaging to the sort of team spirit and work ethic is this trauma-informed care lens. So a real shift in how do we see these patients. So not what is wrong with you, why are you being such a jerk, but what happened to you and why, and how is that impacting how you're acting towards me? And what's happened to me and how is that impacting how I am reacting to you? Next slide. And so this is sort of an unsophisticated schema that we came up with in our system to try and break this down and say, it's like you have this big cauldron between you and the patient. And you both are throwing various things into that soup. And it's got things in it. It's got structural discrimination that's sort of bubbling there. It may have your implicit bias, their implicit bias, your stress, your burnout, their past trauma, past experience with healthcare. And even if you don't see that stuff, it's bubbling there between the two of you, and its vapors are kind of infusing everything that all the interactions you're having with that patient. And it can be really helpful when you walk into a room and that person is already angry at you, instead of just reacting to that person, to realize there is this nasty soup that is there between the two of you, and really to kind of consider what's in there. And also sort of remove, kind of helps you take a little step back and make it a little less personal. Next slide. So kind of with that in mind, and this is a schema that a group of residents at our institution at Brigham developed in thinking and trying to reduce the differential restraint of Black men in our emergency department. And this is kind of a quick gut check. And we joked, you want to trust your gut, but you also want to check your gut. So it's a little bit tricky. So first of all, you have to ask, is there immediate threat to physical safety, right? Like sometimes you just don't, you almost don't have a moment. But if you do have a moment, you want to do this quick gut check and really ask yourself, what are you perceiving as a threat? Is it that the patient's yelling? Are they pacing? Are they just being a jerk and defying instructions? And then how are race, the person's size, their social identity, driving your perceptions of threat? And you can kind of consider your own biases and maybe your team's. And then how is the patient perceiving threat? And how might their past experiences with healthcare or with law enforcement or other systems be affecting how they're reacting to you, and how can we use that information or sort of thought process to make them feel safer? And then, do you feel supported? And I'm going to hand it back to you. Oh, here you go.
I think things to think about, because I think both of you guys made some really good points, excuse me. And I think one thing to really think about when you talk about bias is that, especially when you discuss bias for this difficult population with your staff, it can be perceived that you're saying that the staff themselves are at fault or that they themselves are biased. I think when you say bias, you're thinking, am I making a mistake as a staff member in how I treat these patients differentially? But part of the message we want to give is that a lot of these things are not necessarily in that individual provider or clinician's decision-making, but are influenced by things that are outside the forces of the ED or maybe within the milieu of the emergency department. So some examples that have thought about this is we talked about trauma-informed care, where it's really an approach to how you think about interacting with that patient, and just double checking the way that you're thinking about it and maybe how the clinical team is thinking about making decisions about restraint and sedation. And also thinking about other ways to try to solve the issue of agitation that are not necessarily within the the patient-provider interaction, but looking for larger system solutions. So is there a way for them to divert out of the emergency department to get to a place where they can potentially get actual mental health services before they come to the ED? Another option is potentially bringing in peer support. And peer support could be for our staff during a crisis if they experience an episode of violence, but also for peers of patients. Can we bring individuals in with lived experience to help with that de-escalation process? So first of all, they offload the work from us so that we don't have to do de-escalation as often, but also have them have a shared experience with the patient because they can actually have that rapport better than maybe we can as a clinician. Thanks, Dana.
Perfect. Now we're going to move on to the case. It seems like the patient hasn't been taking olanzapine over the last 2 months, and we decided to hold him for involuntary psychiatric care. And upon learning that, the patient gets really agitated and tries to elope. So with that, I'll invite Dr. Martel and Dr. Wilson to come up. So I think the first question I have for you is, are IM medication that you're giving for agitation, is that considered chemical restraint?
Oh, I'll take that question for 100, Alex, based on CMS guidelines. So there's no judgment here. Has anyone known a friend who's written chemical restraints in the chart? Thank you, Dr. Lopez. You're the only one who raised your hand, but I know all of you have. So look, if you're writing that, please stop. And here's the reason. CMS defines chemical restraints to be no different than physical restraints with all of the stuff that Ambrose just mentioned. So if you write chemical restraints in the chart, you are required to have a sitter, do all the repeat checks, et cetera, et cetera, et cetera, right? And if you don't do that, you are in violation of CMS guidelines. So the Coalition on Psych Emergencies, which some of you may have heard of, in fact, I'm pretty sure Dr. Morgan has because she's one of our steering committee members, has a campaign to end the term chemical restraints. So please stop. Did you want to add anything to that?
What are we doing? We're treating agitation, right? We're safely managing a person in the emergency department. Physical restraints are something very, very different than when we're using medication to assist a patient in their care, to treat them. Don't use
now,
it.
I know the cynical, right, I know the cynical among you are like, well, isn't that just calling it a different thing? And in fact, the CMS guidelines get a little wonky because they're like, why are you giving this medication? If you're giving it to treat the person, then that's not a chemical restraint. If you are giving that medication to them so they don't get out of bed or to restrict their movement, it is absolutely no different than everything the last group just talked about.
So in this case, what medications would you offer and give to the patient?
Oh, I love it. Man, Mark and I have had like a decade of fun disagreeing about this. So I'm going to go first because he's going to give you the truth in a minute. So look, if you're affiliated with psychiatry, like me, I have a secondary appointment in psychiatry. Please don't judge. I am a fully boarded emergency physician. I reach for second-generation antipsychotics. We've done systematic reviews, show they work just as well. The psychiatrists love them. Very little data in the emergency department. In fact, Mark will tell you no randomized trials since about, was it 2005?
About.
Yeah, right about 2005. Because of informed consent requirements. These trials don't qualify for exception for informed consent. Okay, so that having been said, most ED docs are like, you'll get my droperidol when you take it out of my cold, dead hands. And that's fine if that is what you like. In fact, Dr. Martell is a droperidol fan, and I like him a lot. So here's the last thing I'll say about that. If of all of that the data is equivocal, not great studies either way, why do you give this guy the one medication combination of which there's been no randomized trials ever, which is the 5250, right? Why pick that one? Never been studied in the ED. So whatever you pick, just make sure there's some evidence behind it.
It's actually a very complicated question. I think, and Mike and I have gone round and round over the years, but I think the reality is we would agree, use everything we've talked about to this point first. Make sure that you're talking to your patient, make sure that you're trying to have an impact prior to moving towards medications. I think most of us would agree is if you can streamline the treatment, you're better off. Why use 3 drugs when you can pick one? It doesn't make sense. Why use some of the most sedating medications in combination that are actually the slowest acting to manage someone's presentation at this point? So I think you're gonna run into various guidelines or recommendations that are gonna say this for this type of management or this for this type of agitation. The reality is most of us will have some idea of what's going on, whether it's a acute intoxication or whether it's mental health decompensation or whether it's a combination of the both. Pick something that you feel is most appropriate for that patient, but I would recommend trying one, and I would recommend trying one that actually is relatively efficacious in a timely fashion. Fair?
Yeah, and been studied.
And been studied.
Can you share your thoughts on Benadryl?
Do you have thoughts, Mike?
So, okay, so, in terms of antihistamines, right, there is actually, for those of you who are fans of Cochrane reviews, there is a Cochrane review out now, somewhat older, that says if you're going to be giving, say, haloperidol, that if you pair it with another histaminergic agent, in this case Phenergan or promethazine, right, that actually may work better and require less repeat dosing than olanzapine. Okay, so if you're in a resource-limited setting, then fine. What has been called unethical, in Cochrane's words, not mine, is giving haloperidol alone. Don't do it. If you're in a place that you can give something with it, you should be giving something with it. Thoughts?
I would argue that if you have the opportunity to use one agent, that's the safest thing to do for patients. There's pretty good data that says Benadryl doesn't actually do much for anybody, but.
Okay. And this is, all right, we're probably gonna, if he wasn't leaving today, we'd be doing this all evening. Look, I mean, I can't even disagree with that. Just pick a different single agent than haloperidol. So the TREC trials, are, I thought, fairly convincing in that regard. If you're gonna be using haloperidol, give something, probably promethazine.
I'm old. Haloperidol's a lot older than I am. There are a lot better drugs out there.
Yeah, I would agree with that for sure. Yeah.
Just the one last question is, do I need to put this patient on a monitor? Do I need to get an EKG after giving, let's say, droperidol?
Oh, absolutely. Hold him down with one hand, and then the monitor leads with it. No, of course not. Of course not. You wouldn't disagree with that, I'm sure.
What's more dangerous to the patient? Not giving them something because you don't have that data, or managing the patient as safely as you can? I've given a lot of medication over the years in trials and in patient care. And if you have the data, if you have an EKG or you have some strip that tells you what the QTC is, be mindful and you might want to consider that. Practically speaking, you will almost never have that. And don't allow that to prevent you from acting.
Great, thank you. All right, the last part of the case, while attempting to bring the patient back into the ED, the patient spits at the nurse and then punches a security officer who then falls to the ground and hits his head. So with that, Dr. Clement, Lopez, and Thomas are here. Can you describe the scope of the issue with workplace violence and some of the prevention strategies and how you would mitigate and respond to it?
And I think we'll answer these through our slides, so we'll just go forward with the slides. So, also, I like that Dr. Lopez totally hid behind there, but that's okay.
You didn't see me.
So as Dr. Martel would say, at this point, the cat is out of the bag, right? Somebody's swung, somebody got hit. We're hanging our heads in the ED going, oh no, right? Something happened. And so now we're talking about violence. And we had a whole 3-hour consensus type conference this morning on agitation and violence. And are they different? Well, agitation can certainly happen without violence. And if everything was done so far that's been done in this talk happens, hopefully we didn't have violence. But very, 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 very rarely does violence actually occur in the absence of agitation. So they're really, I heard it said, two sides of the same coin. And that's why we're talking about this together. But now violence has happened. So the first thing to be aware of is that we have a definition of violence from the Joint Commission, but that definition doesn't always line up with how we see it. So if somebody comes to you and says, did you experience violence today? Most people are going to be thinking about severe verbal threats. They're going to be thinking about someone swinging at them. But that's not necessarily all of what violence is. And I'm gonna read the Joint Commission statement, because if you haven't heard it, this is all-encompassing. An act or threat occurring at the workplace that can include any of the following: verbal, nonverbal, written, or physical aggression, threatening, intimidating, harassing, or humiliating words or actions, bullying, sabotage, sexual harassment, physical assaults, or other behaviors of concern involving staff, licensed practitioners, patients, or visitors. So just be aware that that's how we're trying to define violence. And if you ask me how much violence is going on in healthcare, I'm going to tell you I have no idea, because I can't really measure that, what they're talking about. And that's a big deal, because we don't know what we don't know about violence. If you can go to the next slide. Oh. So I will say that we have some sense of physical assaults that are happening within healthcare. Physical assaults are only reported to your institution 19% of the time, based on the literature. And I will say, with our own work, we've confirmed that we're right in that area. So most of the numbers that you can see around violence, you can multiply pretty safely by about 5-fold to get a sense of what is the scope of physical violence. But verbal violence, threats, and some of the other horrible harassment, intimidation, and bullying that happens, we have no sense of, and we can't really measure because we, you, me, don't report it. I will tell you that from injury data from the Bureau of Labor Statistics, non-fatal injuries from workplace violence is 5 times more likely to happen in healthcare than any other sector of the economy. It's a little misleading because healthcare is actually 19% of the economy, so we make up a really big, it is, but we're still 5 times more likely. And if you back off from the workplace violence data and put it into all injury that is non-fatal injury, we have about the same rate of non-fatal injury in healthcare as mining and gas and oil abstraction, which is a pretty dangerous place to work. And so, just quick poll. Fatal injuries in the workplace, what's the most dangerous job in America? Pizza delivery. Not kidding. All right, we can go forward. So,
feels bad for their delivery man. All right, now next time tip your pizza man really well, because there's definitely an occupational hazard there. But I do want to just take a poll. How many people have witnessed workplace violence? Okay, so that's why you're all here, is because this is pervasive in our field, okay? And it's been recognized for a really long time. So I just like looked and pulled pictures, not only in the US, but even in Canada. There's all these guidelines, even internationally, that just talk about workplace violence. And the emergency department is actually the #1 place for workplace violence in a hospital setting. So hence why we're here, hence why there's so many people interested. And it's not a new concept. We've been talking about it for a really long time. So why only now are you seeing more pop-up lectures and outreach and political activism about violence? There's been an increase, but I also think that post-COVID, how many people think that everybody sucks now and there's no more filter? I do. I thought that being a doctor, I'd have a little bit of respect. Not a ton of respect, but some. That concept is gone, okay? And it just, the amount of workplace violence in healthcare has just increased. And so Joint Commission made a statement to include parameters around workplace violence, and then all of a sudden, all of our hospitals decided, ooh, maybe we should do something about it. What are we doing about it? So let's look at what the data is and what we want to do in our institution. So, next slide. What I would say is that the vast majority of these government guidelines and regulatory suggestions, they're not all evidence-based. So for me, I think that's a call for research and an opportunity to check what really works. And while we all can say what we think will work, what actually is effective? Some of these interventions are super expensive, and they require system overhauls of how we report and how we respond and training. All of those things are a lot of dollars. Metal detection, a lot of dollars, okay? Is it effective? The jury's still out because there's not a ton of evidence or large multi-center trial about any of that. The best I'll tell you is that the literature really says that there is no pun intended by a violent thing, but there is no silver bullet. There is not one solution. You cannot only invest in one thing and it will drop your rates. It really is multifaceted. So a lot of programs say that you need policy change, you need to look at your environment and really have structural change of what your setup looks like. You need response models, which we do have lots of publications on. Maybe training, maybe not. And we need to be able to somehow identify people that are higher risk. And that is still to be determined. So next slide. How many people have these signs? No weapons. No weapons? No weapons? How many people are enforcing no weapons? Fewer. They're there. Nobody knows how effective the sign is. How many people have code of conducts or no tolerance stuff? Same. Lots of places. There's like very small amount of literature of just putting up signs and what the impact of signage is. We will never know now because there's a lot of tension on reporting, and so even though people are doing things, reporting numbers have gone up. So that study, that ship has sailed. We will never really know the impact, but they're cheap. So that's okay, let's do that because that's cheap. Now, what I will say is it's also okay, this concept, code of conduct and no tolerance, that concept works for inpatient. That might work for ambulatory, but we have something in emergency medicine called EMTALA. So just because you're not nice to me, I cannot say, I don't want to treat you. You gotta figure it out, okay? Because we have a federal mandate to treat everybody. So that's often very complicated and a point of contention amongst staff dynamics of the person that's being insulted and abused or has already gotten swung at the bedside, and then I, as the doc, come up and say, I can't discharge them yet, like they're still intoxicated, or I think they might go inpatient level of care, we gotta figure this out. And it creates a little conflict. There is no such thing as zero tolerance. I hate that term. We have been taught as physicians to be tolerant, to reflect on where this patient has been, why they are presenting the way they are. That's the trauma-informed care model. We cannot have no tolerance. It's a fallacy. Next slide. All right, flagging. We just heard how bad flagging is, and yet flagging is part of everybody's recommendation. And I think the concept was well intended, and there was some evidence at the time that they initiated the recommendation. But how many people here have open entry flag? Like anybody can put a flag in and say, patient was violent, patient was disruptive. Yeah. So unless you lock that down, it's probably not the best idea, because that's where you get a lot of bias, and what I consider threatening may not be what someone else considers threatening. There's one thing when you're talking about objective, but then you really want that to go through a little bit of a filter so you know when events are happening so that you can actually do something about it. So I looked in the literature, and what I think is a really good model, and kudos to the VA because they've had a federal mandate to treat all, so they cannot turn anybody away, and they've been charged with mitigating workplace violence for more years than we've been thinking about it. And they have a system where, both in reporting, but also a multidisciplinary, like they have workplace safety officers, and they are in charge of looking over all the events and having a more holistic approach to patient care, and not only thinking about, yeah, we're going to put this flag in because this patient tends to be violent, but why does that patient tend to be violent? What are their triggers? What can we do to mitigate that violence? What precautions need to be in place? Because they can't turn anybody away. And truthfully, in the emergency room, I just told you, we can't turn anybody away either. And so it's a good model to look at for a setup that includes more than just an ED doc, more than just some administrator, more than just your public safety or security of putting in those alerts, but to really think about a patient as a whole person and what's contributing to their acts of violence. Next slide. And what I would also suggest is to not think of just a flag. So you can tell me that someone's been violent. You can tell me exactly what happened in as objective language as possible. But then what? I'm just scared. And yeah, I'll stand far away and do my 2 arms length and not want to touch them. But then am I just going to expedite their care because I'm afraid of them and I don't want me or my staff to get hurt? No, give me some tools, okay? So if you're gonna have a flag, then tell me what to do to stay safe. And so we wanna make sure that there are action items associated with that. Why is this here? What do we wanna do? Okay?
So continuing along the lines of like prevention, and I'm going to talk about prediction tools for violence. So there's a number of tools available, but it's important to point out that these tools are validated, but they haven't really been studied in the emergency department as much. A few have, but not a lot. So the CDC offers like a number of tools for nursing, for example. They're listed here, like the indicator for violent behavior tool is based on 5 quick observable behaviors based on the STAMP mnemonic, which stands for staring, tone of voice, anxiety, mumbling, pacing. So that's a quick and easy one. But then these other ones, like the Violent Risk 10 or the HCR 20, they're a little bit longer. They're like a 20 questionnaire or survey. And that's difficult, right, to implement in the ED setting. If a patient's agitated, are they going to really answer 20 questions? It's based on their clinical history. And sometimes you don't have access to their past medical history. You can't ask them because they're so agitated. So I think this is an area where we need to look at, do more research on for sure. So next slide. And I know like all the things we talked about so far has been very patient-centered, but just to focus one slide on like the staff perspective, what are some of the things we can do to train our staff? There's a number of resources and organizations listed here that have toolkits that are readily available that are free for the most part, like the Joint Commission has a toolkit that you can download and use to train your providers. There's the Techniques for Effective Aggression Management, or TEAM, which is a training program for all hospital staff, like nurses, providers, physicians. TEAM Essentials, like the basics of like how to de-escalate and agitation management. TEAM Advances, like what to do when you're physically being attacked and how you keep your patients and your staff safe. And it focuses on physical countermeasures that are safe. And then there's train the trainer where you can like learn to train others. But it's important to note that with all these trainings, it's mostly developed for groups that are not physician specific. It's like a lot of training available for nurses, but I didn't see a lot in the literature for us as physicians. And then like who here can raise their hand and say you had formal training on de-escalation or workplace violence management? Like, is that offered in your residency, fellowship training? Like very few, right? So it's something that we could definitely expand on.
Let's go forward one more. We're about out of time, if that's okay. So in 90 seconds, I want to make 2 more points. Can I use the clicker and I'll make us go quick? So I wish I didn't have to talk about this part, but I think you can tell looking at the screen that I think we have to discuss the reality of healthcare-based shootings. Because in the United States, there are 18 a year, okay? And that is a scary, scary number, and we need to realize this. And I do want to talk about the reality of weapons screening and whether it's effective or not in an emergency department. So the first thing to acknowledge is that healthcare-based shootings happen for 2 different reasons. Very, very, very rarely is it somebody walking through the door to your ED and just blasting at the nurse in the triage counter. That's not how it happens. Most of the time, they're targeted because they hold a grudge against somebody, and that requires concealing a weapon, getting through access controls to a target to commit a murder. And there's examples of that, don't have time to go into. The other one is in a fit of rage. If someone has a weapon handy and they get really, really upset, a gun can make that disagreement a bigger problem all of a sudden, right? Screening with newer technology that's been available in the last 2 to 3 years can be very helpful. Metal detection probably is not cost effective. Passive weapons detection, and there are multiple different vendors, probably is helpful because it can identify the shape of things on somebody where they may have weapons, and secondary screening can be done in like 10 seconds. So I do advocate for weapons detection, and I'll just leave it at that. And the last thing I want to point out is about community coordination and the importance of working together. We tend to look inward to our EDs, we look inward to our hospital and healthcare organization for what we can do about violence, but this is a societal, cultural construct, and there's a reason that Dr. Lopez and I are not getting any respect that we thought we would get when we were in training. And part of that necessarily means working with people in your community, and if we're mad about how the police transports are coming into our emergency department and how there may be bias on the part of police, we need to engage with police leadership, we need to engage with community leaders, you need to know your county attorney if you're going to be pressing charges. You need to work with the jail so that they're not just discharging people to your emergency department, or that when they go from your emergency department to there, you can coordinate care both medically and mental health care. So I would advocate for that. And there we go, 90 seconds.